All right. Thank you, Mary, for the introduction, and welcome to everyone to NENIC. It's always a pleasure to come and to speak here at the fall. I can't believe we're in fall, but at the fall symposium, as well as trends. And today I'm going to talk about a body of work that our team has done over the last decade, looking at how do we use health IT to improve patient engagement and also, well, with our eye on the outcome, to improve patient outcomes. And so we'll start, I have to start with my disclosure. Some of this work is supported by the Agency for Healthcare Research Quality, and they may or may not agree with my opinion. So today I'm going to start by giving a little bit of background about the current state of healthcare team communication, which will be no surprise to any of you since you're part of the health team. We'll also talk about patient engagement and what that means and some of the issues we have with patient engagement in healthcare. And then I'll talk about a series of projects that leverage health information technology to improve team communication, patient engagement, and patient safety. And then talk about some of the lessons learned, because obviously when you're doing this kind of work for over a number of years, you learn a lot of lessons. Some of them are welcome lessons and some of them are kind of hard, but there are lots of lessons, and we should have plenty of time for discussion. So all of us go into healthcare because we want to help people, but unfortunately, medical harms are the third leading cause of death in the U.S. behind heart disease and cancer. And we know that one of the major root causes of harm in healthcare is poor communication. There are many, many communication challenges in hospital or other healthcare settings. We have multiple handoffs, so a patient, if they're in the hospital for 3 or 4 days, they might have exposure to up to 30 or 35 staff in that hospital, people coming in and out of rooms, different conversations. There's involvement of numerous professional and paraprofessional providers. There are many different communication methods. So some of us use texting, some of us use telephone, some of us use face-to-face. And so what this means is that very often there are multiple simultaneous silos of information going back and forth, and sometimes the whole team doesn't have access to all the information that's important to make decisions and to work with the patient and family. And so we also know that there's inconsistent beliefs related to the patient and family role on the healthcare team. So over time, we're becoming a lot more patient-centered. I think nurses have always been patient-centered. It's just the degree of, okay? So, there are still inconsistent beliefs related to how activated, how engaged patients should be, and versus just accepting what the care team has to say as what their role should be. So before we did some of the projects a few years ago, we did a baseline data collection looking at team communication in our hospital, at Brigham and Women's Hospital. And so to do this, we're really wondering, how often are the nurse, the responding physician, and the patient all on the same page about, what the patient's primary goal for hospitalization was. And so we asked ICU and oncology patients or their, care partner, the bedside nurse, and the physician from the primary team about the patient's overall goal. And what we found was that only 24% of the time were the nurse, the physician, and the patient all in agreement on this, which, led us to believe that we could improve here, that we could stand for some improvement. This isn't really patient-centered care, if we're not in agreement on this. And so, patient-centered care has been defined as the Institute of Medicine as providing care that's respectful of and responsive to individual patient preferences, needs, and values, and ensuring that all patient values guide all of our clinical decisions. A prerequisite for patient-centered care is patient engagement. Now, patient engagement includes patient activation, so patients who are inquisitive and activated and interested, but they also have tools and interventions that can promote their activation and positive health behaviors. We know from the research that's been done by Judith Hibbard that activated, engaged patients are much more likely to engage in preventative behaviors, such as checkups and screenings and immunizations. They're more likely to engage in healthy, eat a healthy diet, do regular healthy exercise, and they're also more likely to avoid health-damaging behaviors, such as smoking or using illegal drugs. And we know that when we compare costs of patients at the highest levels of engagement and those at the lowest, that activated, engaged patients incur less cost, about 20% less cost. So the first project I'm going to talk about is the Brigham Prospect Project, and PROSPECT is an acronym for Promoting Respect and Ongoing Safety through Patient Engagement, Communication, and Technology. So this was a project that was funded by the Gordon and Betty Moore Foundation. Gordon and Betty Moore are very active in trying to promote better communication in healthcare, and they particularly were interested in improving communication and outcomes in the ICU because Betty Moore was in the ICU, and she received a wrong medication that caused an adverse event. And in response to that, they have donated a lot of money in the form of grants to different organizations trying to improve this problem. And so the goal with the Prospect Project was to transform the intensive care environment through implementation of a patient-centered intervention to engage patients and care partners in the plan of care. And so as part of the, when we first pitched the idea to Gordon and Betty Moore Foundation, what we wanted to do was to provide a portal for the patient and the family in the ICU. We know that very often in the ICU the patient is not able to use a portal, but the family has a lot of questions. And so we were thinking that if we could provide a way to give the family the same information we have, but in a consumer level of health literacy, that we could improve communication. And so as part of that, we did a lot of work with the clinicians in the ICU and very quickly learned that, you know, it's okay to give the patient a portal and the family a portal, but we can't require extra documentation, right? It had to, all of the information that was going to go in that portal had to flow from, you know, wherever the clinicians were doing their documentation. And so because of that fact, this was before we went up with eCare, we ended up developing several other tools for the provider so that we could have that information flow, and we'll look at some of those. So first, the provider-facing tools. One of the pieces of the intervention was a safety checklist. So we heard from, we worked in the MICU at Brigham and Women's, and Tony Massaro is the intensivist there. He leads he's the physician director of the intensive care unit. And, you know, his feedback was that, you know, if you're going to be reusing documentation from the medical team, then, you know, where we communicate safety information is on the checklist. Except when we did this project, the checklist was on paper. And so he convinced us to have a little scope creep, and in addition to developing the portal, to also look at developing a checklist that would be, instead of paper, it would be electronic. And one of the observations about the paper checklist is that even though they did use it every day in rounds, which was an important point because, you know, with technology, we don't want to create tools that don't have a workflow, right? You want to look at what's the workflow that already exists and how can we make it better and more efficient. And so really the vision for an electronic checklist was that in addition, it would have all of the advantages of a paper, meaning that, you know, it would be easy to use and you could review it in the context of rounds, but it would improve the process. So improving the process would mean that it would have to pull from any of the data that's in the EHR so that instead of, you know, during rounds, if they're making decisions about lines, instead of having to look that up in the EHR, that data would pull right to the checklist. on the paper checklist, the clinicians thought it was too easy to skip over an item and say, okay, we'll just leave it in an extra day. So with an electronic checklist, they had to answer, like if any of the bundles weren't pertinent on a particular day, they had to answer why. They had to document the rationale. And so that created a level of accountability that wasn't there with the paper checklist. We also created a multidisciplinary plan of care platform. So one of the things that, through doing different focus groups with patients and families, one of the types of data that patients are really interested in is their plan of care. They want to know, what is it that we're working on and how can they be part of that. And so, again, we knew that we couldn't ask nurses and physicians to be documenting goals and problems in a patient portal. It had to come from their documentation. And so, again, this was before eCare went up. We did develop a multidisciplinary plan of care platform. And so through this platform, the nurses and the physicians could document problems, and then the problems would flow directly to the patient's portal along with info buttons so they could get information about those problems and the goals. And then also the information that the patient documented could be viewed at the top of the portal. So, when I started my presentation, I talked about our preliminary study where we found that, physicians, nurses, and patients are not frequently on the same page about the patient's goals of care. So we thought, well, if they had to look at them when they're, reviewing the plan of care, maybe that would help with care plan concordance. We also had developed an electronic plan of care, and so, when we went into this, we were thinking any problem that the nurses or the physicians add to the patient's plan of care, the patient should automatically be able to view in their portal. But through working with the clinicians, we got a lot of pushback about that. We heard a lot of concerns about patients who couldn't handle that much information or they wouldn't understand that information. And so what we did was we built the problems and the goals with these little lock boxes. And so the nurses or the physicians on their plan could choose. When they added a problem, the default was that it was locked. But if they unlocked it, it went over to the patient portal. So this way they could sort of manage what content went over to the patient. And so this is an example of we also encoded all the problems and the problem list and the goals with the CCC system. And so here are the problems on the plan of care. You can see that these are unlocked, this one's locked. This is a view of the patient portal. The same problem showed up there, and they had info buttons so that they could see the educational content. It automatically took them out to Medline Plus, which is consumer content that is valid and reliable. Now, one of the features of both the provider tools and the patient tools was this microblog functionality. So the patients had the ability from their portal, from actually any page in their portal, to send a message to the care team. So the message went directly out to the care team, and when we rolled this out, we had a workflow around it. So this was another one of those features that was very scary to the clinical team. They wondered, if people were going to be messaging them for chest pain or a bedpan, and so when we rolled it out, we, put some scope around it. So when the patients were educated about the messaging feature, they were told that this is for questions you have about your condition. It's not for anything that's an emergency or anything you need to know right away. Anything that you message about within the portal will be responded to within 24 hours. And now so those are the provider-facing tools, and then for the patient-facing tool, it was really a portal. So this is the InPatient Portal. And so the patients, we've done a lot of research looking at what is the kind of information that the patients need to be engaged and activated in their plan when they're in the hospital. And one of the things they told us is they want to see their care team. You know, they really, so many people walk in and out of the room, and they don't always introduce themselves. And so this would be very helpful. And so one of the things we did was pull the picture from the badges in that database and displayed it inside the patient portal. The home page of the patient portal was their plan of care. So here was where the patients could record what their overall goal was for the hospitalization. And so remember, this is what's viewing in the interdisciplinary portal, so everyone can see what the patient's goal is, what their goal is for the day, and they could also rate the degree to which they felt the care team was helping them to achieve those goals. Now over here, they could see from the care team documentation what the goals were in their interdisciplinary plan of care. They could also record preferences about their care. And so here, this just shows you the messaging feature. So from any of the pages in here, the patient could write a question or a message to the care team. We also had a page for safety. So this pulls from the documentation in the electronic record related to risk. And so we have risk icons, and then the patients could go back, could click onto these and get content, read content about the risks that they're exposed to while they're in the hospital. So if they're at risk for falls or pressure ulcers or DVT, they could read about those and what their role was in preventing that harm from happening. We also pulled the medication list from EMAR. So this is what's ordered for them. And in this particular study, we even had the time that the medications were due. And so, again, along with the medication and the schedule, the patients had the info button so they could go in and read about what that medication was for. And the nurse could use that as an educational tool. We also had a discharge checklist. So here was information about, in this version, it was really very generic. So we're working on another version right now where it's actually pulling information from the patient's discharge plan that's in Epic. But in this particular version, it was really very generic, like what is the follow-up care? So we would tell patients that these are the questions, or these are the things that you need to understand before your discharge. I need to understand where I'm going after I leave the hospital. My family or someone close to me knows that I'm coming home. So things for them to consider. And then they could also look at, click through and look at their discharge plan. And so that was the intervention. So we had this portal that was, and we enrolled patients if they could be enrolled or their care partner. And then the clinicians used the provider tools. Our research question was, does the prospect framework positively impact patient satisfaction, care plan concordance, and lead to a reduction in adverse events and healthcare utilization and costs? It was a pre-post study, so our pre-period was July 1st, 2013, and we went through June 8th, 2014. Then we did our prospect intervention, education, and training. We had a little wash-in period, so this was really the month of June. And then starting in July 2014 through the end of May 2015 is when the intervention was live. So what happened on May 30th, 2015? Does anyone know? Epic went live. So that was a strategic decision. We knew that we would lose our data sources at least temporarily. So we studied for almost a year, 11 months. So the demographics, so in our pre-sample, we had a little over 1,000 patients, actually pre and post, 1030 and 1075. We found that the demographics were similar in both groups, but the people in the post sample were a little bit less likely to be Caucasian. We found that only 18% of the patients could actually use the toolkit. Their mean age was 60. The toolkit users were more likely to be Caucasian and private pay patients. And so what did we find? Well, we found that the aggregate preventable harms, which was we rolled up VTE, falls, pressure ulcers, medication errors, and CAUDI-CLABSI. We saw a 28% decrease in adverse events with the electronic checklist and the tools. We found that the overall patient satisfaction rating using the HCAHPS improved over 20 points, so from 71.8 to 93.3. So these are the highest, the overall rating, but a lot of the sub. So normally with HCAHPS, you improve in one area, but you go down in another. We saw improvements across the board in this particular population. The overall satisfaction with care partners also improved. Now, there was a little bit more of a ceiling effect here because they started out a little bit more pleased or happy than the patients, the care partners, that would be their family. So they went from 84.3 to 90%. We saw an improvement in mean global concordance over their goal of hospitalization, but it's still pitifully low. It went from 26.9 to 34%. So a little bit of a bump there, but not much. And we didn't see any change in resource utilization, so no change in the length of stay or 30-day readmission. So what did we find? So overall, we did find that the outcomes were improved from the pre to the post period. There was much better patient and care partner satisfaction in both groups. We saw a reduction in adverse events. We didn't see a lot of change in care plan concordance, even though the numbers were, that's an example of something that's statistically significant, but clinically not very significant, right? If you go from 26 to 34% on care plan agreement. We didn't see any change in resource utilization. We got a lot of feedback from patients and family that had used the toolkit. Some of the patients, this is a really great idea. We're always asking questions, so this way we won't have to chase anyone down. This is a lot of patients just love the care team page. These are my friends. I've known them for 7 years. It's nice to see their pictures here. So obviously this is a person who comes to the ICU frequently. With something like this, you know what's going on. This is great. Patients need more information about risk, safety, medication, and who's my doctor. So it was really very popular with the patients and families who used it, even though that was a small percentage. And so this is the whole team. The PI on the Prospect Project was David Bates. Sarah Collins was one of the co-investigators. I know a lot of you know her. But it was a really diverse clinical, IT, and also research team. Yeah. Sure. This one or the other one?
So what I'm interested here is, the results are fantastic. Can you explain why there was no change in resource utilization if you had that significant reduction in adverse events, right? Because if I think about adverse events, they cost money.
Yeah.
And so there would be some reduction in.
So look at it's just because, sure. So the question was, with such a large reduction in adverse events, why didn't we see a reduction in resource utilization? So we didn't do a full cost-benefit analysis where you would have included the cost of the adverse events. One of the problems we have is it's very hard to figure out how much care costs, right? Like if you try to get the price of something, it's not easy. So what we did is we used as proxy measures length of stay, and we also used 30-day readmission. But if we actually use the price, if we use the cost of those events, and if we knew what the true cost was there are, people who get their doctoral degrees in figuring out how much these things cost. It should be more transparent. It's not. So it wasn't one of those things that we could easily figure out. But that is such an important question, right? Because so now we have this technology. Our paper just came out actually in August. So it's in the Critical Care Medicine. So it was finally, published. So, to get people to use a new innovation like this, you do have to publish to show that it went through the peer review process and that, you have good results. But you also have to convince people to put out resources to use it. So that's hard to do. So right now, we did get a CRICO grant. So we're actually doing the ICU we're partnering with the ICU at Faulkner Hospital, and they've rolled this out, and they're using it right now, and also the CCU at the CCU at Brigham and Women's Hospital. So one of the things we're looking at is, this works really well in the NICU, but we've seen so many projects where they're sort of one-offs, right? So, it was very well tailored for the clinicians and the patients and the families in the NICU, but how well is it going to work when you put it into a different type of ICU? So at the Faulkner, they have medical surgical ICU. So we never had any surgical patients because we have separate ICUs for those patients. And so, and those teams around completely differently. So we've learned a lot about, what the differences are and how, what the workflows are. And so for any informatics intervention, you really have to think about workflow and get feedback and sort of tailor how you implement the intervention based on those workflows. Sometimes you can change the workflow, but you shouldn't assume you can, right? You have to really look at what are the process, what's already being done. The workflow is so complex, and the whole team is so busy that you can't assume that you're going to be able to change that. You have to look at what people are really doing and try to help them do it smarter. Yes. Yeah, so the dashboard came out of this. So after we finished this project, we did get another grant to try to generalize this checklist to medical patients and surgical patients on like step-down units or general care units. And our intention going into that project was to have them use a checklist, but there was no way they were going to use a checklist. They said, we don't use checklists. We're not going to use a checklist. They didn't have the workflow for it. But they said what would be helpful is if this could roll up into a dashboard so we could see at a glance how our patients are doing on the different measures we're looking at across the board every day. And so that's what we did is they are using on all of the medical, all the neuro, and some of the oncology units, they have dashboards where they can see, on a unit level how they're doing for all the different bundles, but then they can click in and see from the patient how, where there are issues. So the great thing about the dashboard is that it pulls from over 30 places in eCare and creates a display to support decision making. And so with this project, we think, with only 18% of the patients using the portal, that's probably not what made the difference, right? It probably had to do with the clinician tools. We think it was the checklist, where that was used every single day and round. It pulled in all the data from, we still had, even before we had Epic, we had all the medications, we had all the orders. We were able to really populate that to support decision making. Now the dashboard takes it to the next level. And so in this CRICO grant, we're implementing this at Faulkner and in our CCU, but we've added the dashboard piece to it. That's good, yeah. It's actually, they put us to shame all the time. That's a really strong team over there. They have, it's hard to roll out a new project, and at Faulkner, things seem to go smoother than, sometimes when we're doing it ourselves. Yeah, it was great. Any other questions about Prospect? Okay, so now I'm going to talk a little bit about fall tips. So a lot of you know about fall tips, tailoring interventions for patient safety. So this was a 2-year mixed method study funded by Robert Wood Johnson, and we conducted this study 10 years ago, from 2007 to 2009. And so at that time, we didn't have evidence about what intervention protocol is effective in inpatient settings. There was a lot of evidence about outpatient, community, what you need to do to prevent falls in community-based elders and people living in the community. We had a lot of evidence about risk assessment. We knew what put people at risk for falls in the hospital, but there was no intervention protocol. But there had been a lot of studies done for over 30 years. So we decided that we would first start with qualitative work to kind of look, talk to nurses, talk to patients who fell in the hospital and other professional and paraprofessional providers to find out, what are we missing? What do they think is not just effective but feasible in the hospital? And then we used that to design a randomized control trial to, test the toolkit we developed. And so from that study, from the qualitative work, we came up with our set of requirements of what this fall tip toolkit had to do, or had to be. And so some of the things we learned was that we had to leverage existing workflows. So couldn't, change. We heard again and again. We did this at 4 partners hospitals, Brigham, Mass General, Faulkner, and Salem. And we heard again and again, don't give us more work. Just look at what we're doing. Help us figure out, how to do it more streamlined. And we saw at every hospital, they were all doing risk assessment, fall risk assessment, either every shift or every day. And they were all hanging high risk for fall signs up above the bed, and so, or on the door. So we knew that those were 2 workflows that we could try to leverage. We also heard a lot about how important teamwork was, that, we're all redoing our hospitals and we're going from multi-bed to single-bed rooms, so we don't have, you put one patient in a room where the patient might be confused, and when the confused patient starts to climb out of bed, the roommate will put the call light on. We don't have that anymore. And so if the nurse is helping a patient and is not available and someone goes to answer the light, they need to know, how do I help this patient? We need to be able to communicate the risks and the prevention plan at the bedside. We also know that signs, one-size-fits-all signs like high risk for falls are not effective, because on medical units, most patients are high risk for falls. And the interventions you need for patients who have a cognitive disturbance are different than those who have a gait disturbance. And so that's why, these one-size-fits-all signs don't work. And surveillance, as we're walking down the hall and you're looking in the room, if you see a patient getting up and they're supposed to be walking, we want to encourage that. But if not, you need to know if you have to run and help them. So tools to support surveillance were part of this set of requirements. And so this is a screenshot from the original fall tip toolkit. You can see that this is the more small scale over here. And then these are the interventions that we learned in the qualitative work were both effective and feasible in the hospital. And they're really very simple things. And the way this works is that as the nurse does the risk assessment, on the left side, the interventions that are most likely to prevent a fall with that individual risk factor are automatically selected on the right. And then when the nurse finished doing the risk assessment and filed the assessment in the plan, it would automatically produce 3 documents. So the first was that was a bed poster. So I mentioned that one of the workflows that we had observed was high risk for fall signs, and that those weren't that helpful. And so what we developed were personalized posters. So these posters had the interventions that were related, that addressed each of the areas of risk that were present. So for this particular patient, Jane Doe, you can look at her sign. If you don't know Jane, you know that she does have a history of falls. She's much more likely to fall again and under similar circumstances, so it's important to learn about that previous fall. If I answer a call light and she says she wants to go to the bathroom, then I can see here that she needs assist of 1. If she needs assist of 2 or she was independent, that would also display. If she's in a multi-bed room and there's a cane and a walker on the windowsill, I know that the walker is hers, that I can walk her to the bathroom with that. And if she does go to the bathroom, I need to stand there with her because she has a bed and chair alarm icon, which means that either she's confused or she doesn't reliably call for help. So here, what we try to create with fall tips is clinical decision support. It's a core set of information you need to safely and effectively have at the bedside to care for a patient who's at risk for falls. We also produced a one-page patient handout. And so the idea here was that, the workflow is you do your risk assessment, you teach the patient about their risks, you teach them about the interventions and how they can work with us to prevent falls. And by the way, do you mind if I put this bed poster above your bed so the rest of the team will know how to help you too? And then in the hospitals where we had paper plan of care, and at this point we did have paper plan of care at Brigham, we had a paper fall prevention plan. So same information, whether it's the patient handout, whether it's the a bed poster or what was in the paper chart. And so we did have this live for 6 months in the 4 hospitals, and we found that there were fewer falls in the intervention units than the control units. That patients age 65 and older benefited most from the toolkit. It was very effective with older people. We didn't see any significant effect on fall-related injuries, but we weren't powered for that. We would have needed about 80,000 people. We had about over 10,000 in this study. And so what we learned through that fall tips, the first fall tips study, was that fall prevention is a 3-step process. That you need to do a fall risk assessment using a valid and reliable tool. You need to take the results of that assessment and use it to create a tailored or personalized care plan, individualized. And then you need to consistently implement the intervention. And we call that the 3-step fall prevention process. And so strategies and tools that would facilitate this 3-step process, we said, should prevent patients from falling. After the first fall tip study, we did a case control study because we wondered, fall tips, we had a 25% reduction in falls, but we know from the literature that more than 90% of falls are preventable. And so we wondered why some patients who had the intervention still fell. And what we found was, through doing the case control study, was that the most common reason why patients in the hospital fall is because they don't follow the plan. Not surprising, right? And so what this got us thinking about was, our protocol was nurse does the assessment, nurse develops plan, nurse teaches patient about it. But then we did focus groups and bedside interviews with the patients, and what they told us was that the nurses had always told them that they were at risk for falls, but they didn't believe them, especially the younger patients. And so they didn't understand why they were independent at home, and then they came in here and were considered a fall risk. And so this led us to believe that we needed to create tools that would engage patients sooner, while we were doing the risk assessment, while we were developing the plan. So if we do our risk assessment with them, hopefully they'll believe that they're at risk. If we develop the plan with them, then hopefully they'll buy into the plan more and help us to consistently implement it. And so coming out of this, we said, well, we want to develop more tools that will engage patients in all 3 steps of the fall prevention process. And so again, the rationale being that doing an assessment with the patient facilitates their understanding of their personal risk factors and their plan to prevent a fall. It promotes their understanding of their role in fall prevention, that it's not just us, that this is a team effort, and that it also facilitates patient and family partnership in ensuring the plan is carried out consistently. We heard a lot from nurses that, family would come in and visit, and it would be right after they left that the patient fell. So again, not only engaging the patient, but if the family is involved, making sure that they understand the patient's risk factors and understand what the plan is so that they can help us implement it consistently. And so a couple years ago, we got a grant to develop patient-centered fall prevention toolkit. So we're starting with fall tips, but thinking about, how do we engage the patient and family more. And so, as background to this particular study, we did a lot of surveys, observations, semi-structured interviews, we wanted to see, at baseline, how much did nurses involve patients in doing the risk assessment and developing the plan? Did patients even know they had a fall prevention plan? And so through this process, we developed a series of prototypes. We did a lot of bedside interviews. We met with patient and family advisory councils to really work on the tools that we developed. In the design phase, we created PowerPoint mock-ups. We partnered with the systems engineering group at Northeastern University. And so that's kind of a different skill set. We do have human factors experts at partners that have worked with us over the years, but we hadn't in the past worked with systems engineers. So really looking at, what's the workflow from a systems engineering perspective, and then helping us to look at how we might insert some tools to help with the patient-centered piece. And so we developed a series of prototypes. We did a lot of usability testing, and we also looked more at the icons. So the icons that we developed originally with fall tips, we tested on nurses, physicians, like professional and paraprofessional providers, and but not patients. And so in this phase, we actually asked the patients about the icons, and it turns out they didn't like them that much. So we figured if we were going to have patient-friendly tools, we should probably refine the icons so that patients liked them too and could understand them. And so we had different prototypes. So this was an early fall prevention prototype in the patient's portal. And so we had translated the Morse Fall scale into patient level of health literacy, and then used the interventions that we had learned about in fall tips. And these are the original icons. This was an early version of a patient tool that was in use, through the fall prevention committees. Some of you might have seen this before because we have used this. After fall tips, we got a lot of feedback that not every hospital can put this in their EHR, so there should be a paper version. And so I had gone over to Taiwan to do a fall prevention workshop, and a nurse over there showed me something like this, where they had the risks, the areas of risk on one side, and on the other side were the interventions. And I said, that's great. That's like fall tips, but it doesn't have the decision support. But what they would do is, in Taiwan, they have a very low fall rate, and their major problem is educating all of the family about the fall prevention plan, because the patients are never really without a family member. Their problem is that there's handoff between the family members, and they may or may not pass on information about the fall prevention plan. So they use something like this, and they had it in the room so that when the new family would come, the family members could sort of hand off the fall prevention plan. So we had mocked up something like that here, and some of the units were using it. And so through our series of interviews with the different stakeholders, we found out that the icons had to be more patient-friendly. We had to do a series of iterations with the patients and the families and get feedback. We even had families drawing icons for us to try to, some of the assistance icons, like Assistive 1, Assistive 2, the patients thought it looked like they were prisoners and they were being escorted by a robot. So we really had to work on that. With the electronic tool, we heard that we needed to improve the visual appeal of the user interface, that using radio buttons were very hard for patients to use, especially older patients, that we needed to simplify it. It had to be linked up with the Morse Fall scale and the electronic health record in our eCare. And for the paper tool, that yellow tool, that we should simplify the visual display, try to optimize, make the icons bigger for the patient and family, and that we needed to figure out how to integrate clinical decision support into the paper, because, the the risk factors are there, and all the evidence-based interventions are there. But remember, you need different interventions if the patient has cognitive issues versus a gait disturbance. There had to be a way that every patient could get an evidence-based plan regardless of the skill level of the nurse. And we also needed to develop a Spanish version. And so this is just one of the tools that we use for these icons. So we would take these charts out to the patients, and we would show them the icon, and we would ask them to rate on a scale of 1 to 4. 1 meaning this is a really terrible icon. You shouldn't use it. You need to start again. 4 means it's great. You don't have to do anything with it. Our goal was to get a 3 or above for all the icons with the patient. And so you can see some of the differences from like the first to the second in all of these icons. This one was particularly bothersome to patients. They didn't like it, saying that they had gears in their heads. And so this was like for the mental status on the Morse-Ball scale. So really the intervention is that, the patient needs to call for help. And so showing the call light they thought was a better idea. And so this was an early prototype of the paper version, the poster, with using color for clinical decision support. And so here you can see that, the way it works. So as you do the risk assessment, you can see the interventions that go with each of the areas of risk. And, we brought this out. People like this a lot better than the plain yellow one. But they thought that it wasn't clear enough, which color went with what, that it could be, they wanted us to make it more colorful and a little more definitive about what the colors meant. And so we continued with that. This is actually a late version of the paper fall tips. So here you could see that there's more color over here, so it's easier to see kind of what goes with what. And one of the other things that we ended up adding was increased risk of harm. So at least at the Brigham, we do the ABCs of harm. And what we heard from our patients in our focus groups is that if they knew they were at increased risk of harm, they'd be much more likely to follow the plan. And so we added this up here, so if the nurse, when they did the ABCs of harm, it would remind them to teach the patient that, yes, you are at increased risk of harm because of, and they would tell them the reason. But this was the final version of the laminated fall tips. We had both a English and a Spanish version of that. And I think this is. And so one of the things I didn't mention, in addition to collaborating on this one with the systems engineering folks at Northeastern, we also collaborated with Montefiore Medical Center, where they have 60% of their patients, Spanish is their primary language. And so we wanted to test this not only at the Brigham, but also in a hospital that was much more diverse to see if it would work in both settings. So just in terms of the usability, so we looked at the usability of, this is the paper tool, so from pre to post, we had, significant improvement over most of the, we used the system usability scale, and we saw improvement over almost all the categories, from the yellow one to the colored prototype. And this was the rating by the nurses who actually complete the assessment. Then we pilot tested the prototype from January through June 2016. We targeted units that had fallen injury rates above the hospital and the state mean. So they were really, above what their benchmark was, as well as Montefiore Medical Center. And so what we found was that, the adherence was pretty good with the protocol, above 80%, 82% at the Brigham. We saw the fall rate, the pre-fall rate was 3.28, and it went down to 2.8. But we also saw a decrease in the injury rate, which we didn't see in the original fall tip study. The injury rate was high in these units. It was about 1, and it dropped to 0.54, so it really went almost in half. Let's see, do I have I don't have the Montefiore slides up here too. at Montefiore, their adherence was higher. It was in the 90s. Their fall rate stayed about the same, but their injury rate also fell quite a bit. And this paper was just published in August of the issue of the Joint Commission Journal of Quality and Safety. So we've gotten a lot of emails about this, people wanting to try the poster. So, so what are the patient-centered fall prevention tools? So we just went over two of them, the paper, and now we're going to talk about some of the electronic tools that came out of this project. So there's the web-based and mobile patient portal to access fall tips. We also have a patient safety plan screensaver for the patient and the care team members. So this is the patient's, handheld, so they can download. We have a Prospect app, so they can download that, and fall tips is part of that. So they can see whatever the nurse. They can see the nursing. They're based on the nursing documentation, e-care. They can see their fall risks and their plan on their handheld. We also have fall tips in the portal now, so patients can also look at their risks and their interventions in there. They can get more information about those, along with the other content that we had reviewed earlier. So this particular, this is the screensaver. So I would say this is probably the most popular tool that we developed. So with fall tips, we're printing out, we're hanging the sign above the bed or in the patient's room. So here, instead of having to print anything, this pulls directly from the e-care documentation. And so you can see on the left-hand side here, these are things related to patient preferences and needs. So for this patient, we can see they're hard of hearing, that they need a translator, they need glasses, they have a latex allergy, and they have a left arm restriction. So all those are pulled from the documentation fields in. None of this requires extra documentation. The patient's fall prevention plan pulls right here, and then we have other, like if a Brady score is low, they'll get the turn off in. If the patient, their diet pulls up here, so if they're not supposed to eat or drink or whatever their diet is, that will pull here. This person has a catheter, and so they can learn more about preventing clotting. They also have, they're on, medications to prevent ulcers, so they have that icon. This patient must have restraint. But they can access the same information on their portal and go into information about each of these risks that they're facing while they're in the hospital and learn more about the prevention plan. So the top, it has the patient's name, and it says actually their safety plan. And so the patients really like this because it has their name on it. It's personalized for them. The nurses use it as an educational tool, so you can use it to, provide patients information about their safety plan. We've had some kind of interesting stories about it. We've had a patient, one of the nurses was telling me that she had a patient who was very confused, but the patient liked the screensaver because it was their name, and they kept saying, "That's me, that's my name up there." We had another patient who was waiting for his diet order to change because he hadn't eaten in 12 hours, and the nurse was saying, "You don't have," and she said she was standing there, and then all of a sudden the icon changed, and he's like, "I can eat." So, and then, having the fall prevention icons, that means that they're there. You don't have to, hang anything, and they're up to date all the time. Now, we're looking at, are there differences in patients' knowledge of their plan, whether they use this form of fall tips or whether they use the paper or the laminated poster, because, sometimes you can automate things too much, right? So just having it there makes it very easy for the nurse. But we learned through our research that if we don't engage patients in identifying the risks and the interventions and reminding them about them, that they're more likely to fall. So we're looking at that too. Now we have had units that have gone up on this. We had we had 2 oncology units that went to this. They couldn't wait to go to this. They were using the posters. And after a month, they asked for their posters back because they said that this was positioned in the patient's room in a place where it wasn't easy for the patient to see. I guess there's a lot of stuff in the room. And the computers are at a weird angle. So when the patient's in the bed, they can't really see it. They could see it from their chair. And they actually had an increase in fall rates. So they asked for their posters back. We gave them back, and their fall rate went down again. You know, it's just one of those things where you really have to, you know, I think if nothing else, this project has taught me how important it is to, you know, have evidence, right, but have different ways of applying it, really looking at the environment and making sure that, you know, you have different options so that you really can personalize the intervention. So I think that this project has been great because we've been able to identify different ways to apply fall tips in different environments. So lessons learned. So we learned a lot from these different projects. So, you know, obviously multidisciplinary involvement is needed to improve clinical outcomes. So when you think back around, like back to the prospect study, we did that in the ICU. We have a very good, I would say, infrastructure at the Brigham to do the project because we had good practice committees, we had good involvement of the nurses and the physician. You really can't, you know, do a successful intervention. You can't develop successful schools if you don't have access to the clinicians who really understand the workflow. And so, you know, having this multidisciplinary team was really helpful. Also having clinical champions, you know, the practice committees, those are invaluable for being able to bounce ideas off and get suggestions for, you know, how to address issues that we have in the workflow. With the checklist, documenting reasons why safety checklist items are not indicated. So, you know, just by adding that to, you know, the electronic feature where they had to document why, that is what we think probably made the most difference in that prospect study. You know, obviously patient care units are busy. There are lots of barriers to adoption. It's so hard to change practice because really we're all working very, very hard. It's difficult to get people to do something different, even if it's perceived as something good, right? And so, you know, knowing that going into it, you know, you need to plan for that. You need to plan for what we call the inertia of previous practice, right? You know, how do you change that? And, you know, working with the champions, giving feedback about performance in a positive way, peer coaching, those are the kinds of things that are really required to change practice. Some patients lack capacity or they don't have a care partner. So, you know, we need to think about how do we make sure that we're always meeting the needs of all of our patients. You know, not all patients want to use electronic. I've had patients say, I don't use that stuff at home. I don't want to use it here, right? So we have to think about, you know, different tools for different populations. We found that in the prospect study that lack of access to the portal outside the hospital was a barrier. And so in the Patient Safety Learning Lab with the portal that, you know, we're using now, the family can access it also from outside the hospital. They can download the app and they can get into the portal from outside the hospital. A device strategy is needed. So it's not trivial to be giving iPads out to patients. So you really have to think that through. You have to think about what kinds of accessories, if any, are you going to have? Where are you going to store them? How are you going to clean them, both the data and then also the bacteria off them? So, like, the security concerns are, you know, big. We worked a lot with the partner security team to try to help us figure that out. And then the enrollment. The enrollment was so hard in our first study, in the prospect study. I think one of the reasons we had 18% of patients is we had a 10-page consent that they had to sign to participate. So we worked with the IRB, and for this current study, because we're not providing any information that they couldn't, you know, they don't already have access to, we were able to just have them sign the health, health information systems permission form, and they can give verbal consent to participate in the project. We learned that patients want to be engaged, but there's still a lot of challenges. There are a lot of patients who are not activated, they're not engaged, so we still have a ways to go there. We need access to content for non-English speaking patients. We've been trying to do that with Fall Tips. Now we have, as part of our current Fall Tips project, they're implementing it at NYP, all of their hospitals and the Montefiore hospitals, and so they have included other languages. So they have NYP, I think they have 14 languages for the signs that print out. So they had all those translated and put together. So, developing content like that I think is really important. Understanding the goals of care concept. So a lot of patients don't necessarily know that they should have a goal related to their care. And so this was a barrier when you're trying to ask patients about their goal. Some of them will say, well, my goal is whatever my doctor says, right? Or, we need language to talk with patients about their goals. So if we want patients to be activated, they need to be more familiar with, what it means to be an activated patient and what these goals are. We need a lot more work related to workflow integration and clinician buy-in. I think that we've made a lot of progress. I think clinicians use technology in every other aspect of their lives, so they're a lot more open to using it now when they're in the hospital, but that we still have a ways to go. So just in conclusion, making care better will involve partnering with patients. It is probably going to require both high-tech and low-tech solutions, and clinician attitudes still have a way to go, but making a lot of progress. We need to be highly multidisciplinary, and probably the roles of nurses and other clinicians will change. I think we're seeing that, every day. And health IT is opening new doors, so we need to take advantage of that. Thank you.
So let's take some questions from the audience. I'm also going to minimize this a little bit in case I'm from the remote.
Oh, yeah, that's really, yeah.
If anybody who is participating remotely, if you want to type in a question for Patty, if anybody from the audience.
We didn't look at staffing, no. The way we controlled for that is that we selected the units that participated were similar types of units, so they sort of all had the same problem, so we had control units that were matched to the intervention units, so they had similar staffing models. But no, we didn't look at staffing data. That would be a good thing to do, though.
Your point earlier,
Yeah, so with the in the interviews, one of the things that we learned is that, the patients told us that the nurses definitely told them that they were at risk, but a lot of times it's how they tell them. And so if they're telling them, hey, you're at risk for falls, make sure you call me, and they're running out of the room at the same time because they're worried about other patients, the patients perceive that as, well, she's got a lot to do, and so a lot of them, especially the younger ones, they think, well, I'm the healthiest one here, so I can help myself and give this nurse a little break because they're really busy and they're running around, and I can just do this. I do it myself at home. And so in order to kind of break that down, you do have to take the time to teach the patient and make sure that they understand that there really is risk for them. They have to perceive risk, right? And I don't think very often they do if we don't involve them in doing that risk assessment, developing the plan with them, and then continuously reinforcing it. We involve the PCAs also in training. PCAs are great. They're in there all the time. They really depend on the signs, and, that can be part of their role is reinforcing it with the patient. Oh, sorry. The question was, did you consider staffing in your model when you were doing the analysis? And we did not, unfortunately.
I have a question.
Okay, Mary.
You've done such fabulous work. Is this being integrated into the Epic?
It's in Epic, Mary.
So is it in multiple hospitals in Epic?
Yes, it's in Montefiore Medical Center in Epic, and actually they have many hospitals that are using it. At New York Presbyterian, they have, I forget what system they have. They're going to Epic, but they have it in a different system.
Are they promoting it? I mean, to other people throughout the country. I mean, it's really exciting to hear that it's in New York Presbyterian, Montefiore.
Yes.
I mean, it's exciting. It's really exciting work and so substantive. I wonder if it's going over. It'll be exciting to see it go on.
Yeah, so with this R18 grant from ARC, our job is to try to create the tools for spread so that it can be used in our health systems but anywhere.
We have a question from the field. Did you find an increase in family engagement after implementation of patient engagement tools?
We did. So, you know, especially when you think about the ICU, it's a little bit tricky to engage family because imagine you have a family member in the ICU, they're pretty sick. So what we found was that timing is really important. Like when the patient first gets there, it's probably not the time to try to hit them up with a portal because they're a little bit overwhelmed. But what we found was that by approaching them the next day, by then they have a lot of questions and they really appreciate a way to get information. It helps them think through what's going on and prepare for their communication with the team and for their meetings with the doctors and the team on round. So we did find that they did engage with us. Now with the messaging platform, we found that most of the time when patients sent a message, the team addressed it at their bedside. They didn't necessarily want to get involved in. I think they had a little worry about whether, you know, there'd be too much texting going back and forth. So they did discuss it in rounds. So when I showed you the multidisciplinary plan of care platform, if the patient wrote a message to the team, they could view it right there. So as part of their checklist, they had an item which was, has a patient or family, you know, asked for any information in the last 24 hours. And so if it was something that needs to be discussed by the team, then they would do it there as part of rounds and make a decision about, you know, who would approach the patient and address it. No. Oh, sorry. Yeah, the question was the messaging part of the electronic medical record, and the answer is no. So what, you know, this was a research study, so if we had done it as part of, you know, if this was turned on as part of operations, it might have to be. So we had argued it wasn't different than texting, which isn't part of the medical record. So, and we were able to do that. But, yeah, I mean, there's a lot of valuable information that can be there, so you could argue maybe it should be part of it. But that wasn't resolved as part of this project. So the question was, do younger patients use the patient engagement tool, the portal, more than the older patients? They did, but a lot of older patients did use it, or they had a family member who wanted to use it. So we had a lot of patients who said they didn't use technology themselves, but their daughter they wanted their daughter to use it, or they wanted their son or their spouse to use it. And so even if the patient wasn't, if they didn't want to use it, we still tried to get them to identify a care partner. The idea being that, you know, even if patients can use it, they're in the hospital, they're in the ICU, so they're pretty sick. So chances are they're not going to be able to use it all the time. And so having a care partner that could make decisions and be informed and think about, you know, the plan of care when they're not able to, we saw that as a positive.
patients not knowing like the word goal or that they have a goal, were you able to identify some other key words that might help the patient understand, like how to translate the word plan of care or goal into something they might understand? Like a huge area of
So the question is there, what kinds of words can you use with patients to help them understand what a goal is? And so, we didn't have a scripted phrase, but it was really more around, tell me what you're hoping to get out of this hospitalization. And, in those sorts of words, not so much using the word goal or tell me what, you hope to achieve today. So in the ICU, the plan of care is evolving very, very quickly. And so, I think originally we had just goal for the hospitalization, but very quickly learned that we needed to break it up a little bit because, they could have a goal for the hospitalization, what they were hoping to achieve by the time they left, but they needed to have something to, hold on to for the short term as well.
Well, if there are no more questions, we'd like to thank Patty for your wonderful presentation.
Oh, that's nice.
And hope you come back.
Anytime. Yeah.
And with the people on the phone, if, let's see, Annie Bowen, Mary Zasada, and Katie Ann Zink, if you're on the phone, I didn't see you that you had, I see Mary was there, but I didn't see the other two. So just send me an email at program@nenic.org, and that will conclude the presentation for everybody on the phone.